Good evening, everybody. I'm Dr. Rick Lehman for another segment of In Your Corner with CORA, August 26th, 2020. We're still in the midst of a pandemic, a national and international pandemic. So everybody is still concerned about COVID. And COVID actually has put the kibosh on quite a bit of high school, college football, maybe NFL football. So we'll see how this all plays out. We're early in the season in terms of NCAA hasn't started yet, high school hasn't started yet, but a lot of football has been canceled, Big Ten, Pac-10, etc. So we've got a very, very esteemed group tonight, and I want everyone to introduce themselves. So I'll start with Brett. Brett, please introduce yourself.
Thank you, Dr. Lehman. My name is Brett Kolnick. I'm the regional manager with CORA Physical Therapy. And I've been with CORA for 3 years. I've been a physical therapist close to 20 years. And I'm the regional manager of Kentucky, Tennessee, and the North Bristol, Virginia region.
All right, so let's introduce Dr. McGarry. Dr. McGarry, could you please introduce yourself?
Sure thing, Dr. Lehman. My name is Dr. Tim McGarry. I'm an orthopedic surgeon. I've been in private practice now for about 28 years. I practice down in the Bristol, Virginia area.
Thank you very much.
My name is Charles Peters. I'm a physical therapist, senior clinic manager, East Tennessee. I've been providing sideline coverage for football for the last 5 years. Happy to be on.
And just real quick, Brent, why don't you give us a short history of your football history, and Charles as well, high school, etc. Give us a little background on your football history, please.
I played high school football at South Broward High School in Hollywood, Florida. Played outside linebacker for 4 years there, and then got a football scholarship. Played at Eastern Kentucky University, outside linebacker from a long time ago, from 86 to 90, with Eastern Kentucky University. Captain of the team, all conference, and played 4 years, 5 years really, redshirted. 4 years we were on a top 10 team each year, 3-time conference champions, and had the opportunity of playing within 4 years, played probably over, with the playoff system, probably played over 52 games, and several injuries, but nothing serious. A lot of practice, a lot of hits. That was back when we played football, when there weren't things called concussions back then.
And Charles, can you give us a little history of your football background?
Yeah, played just general football, basketball, baseball in high school. Ended up having actually rotator cuff surgery, which kind of put me out for a year after high school. Went back to playing baseball after that surgery at King College in Bristol at the time. So that's kind of where my journey transitioned from one to another, how it ties in today.
Charles, what position did you play in high school football?
Linebacker.
A lot of linebackers here. Dr. McGarry, did you play any football?
I did. I played in high school.
There we go.
I wasn't tough enough to play linebacker. I played quarterback.
We tried to hit you.
I tried to stay away.
So we're going to jump right in. We're talking about shoulder injuries and primarily shoulder instability. So I think this will be a very good, lively conversation here. And starting off with Dr. McGarry, could you please explain the biomechanics and the mechanism of anterior shoulder instability and posterior shoulder instability as it pertains to football?
Sure. Well, the first thing, obviously I always never forget that one of my professors used to describe football. He used to tell us as residents, football's a contact sport. Our resident used to say ballroom dancing and drive-in movies are contact sports. Football is a collision sport. And that really does explain it. It's really just such a high velocity injury. So the mechanism of injury, shoulders, obviously, it's a very shallow joint, so it's very predisposed to having significant injuries, obviously, because you have to use your shoulder a whole lot more than you have to use a joint like your hip joint, which is much more of a ball and socket joint. The mechanism of the injuries, obviously, we see anterior dislocations about 5 times more common than we see posterior dislocations. Anterior dislocations usually come with an abducted, external rotated arm, and it's basically a torquing injury where it basically forces the humeral head out in front of the glenoid. It can then, obviously, the injury entails itself. It's associated with a significant soft tissue injury, and it's also going to be associated with a bony injury as well. Post instability is obviously not nearly as common as anterior instability, and it usually comes from a forward flexed arm with a firm push from the front. Obviously, we see that much more commonly in down linemen, especially offensive linemen who have to reach out a lot to stop opposing rushers. Basically, the same kind of thing. It's associated with significant soft tissue injuries in the posterior aspect of the glenohumeral joint itself too. It's interesting. There's a study that's been done that shows that professional football players, especially professional linemen, are at about a 15 times increased risk of having posterior instability problems when compared with the normal population. So it is an injury that's pretty much specifically associated, that we see mostly associated with football.
Thank you. So while we're on that topic with Dr. McGarry, real quick, can you explain to us the difference between anterior dislocation and anterior subluxation, and in terms of linemen, posterior instability, i.e. posterior dislocation versus posterior subluxation? Because I think there's a lot of, we see subluxation that's certainly not as obvious in our football players and our linemen, especially our offensive linemen. And it's a little harder to diagnose than somebody who comes in and their shoulder's dislocated. They go to the ER, they get reduced. Pretty easy to visualize that. But I think there's an incidence of subacute instability or micro instability in posterior shoulder, which we see, and it's certainly much more difficult to diagnose. So maybe you could give us a difference between subluxation and dislocation, both anteriorly and posteriorly.
Sure. Basically, the way I sort of look at that is sort of the whole definition of instability. It's almost on a spectrum where it comes to, the diagnosis of laxity, which basically is just instability, but it's asymptomatic. So the next spectrum is subluxation, which is symptomatic instability, but you don't have a frank dislocation. And then it goes all the way to the realm of a dislocation, where you have actually dissociation between the articular surfaces of the glenoid and the humerus. Obviously, you're exactly right. The things we see that are really hit you in the face, and things that really get people's attention when you see somebody gets a frank dislocation, because that's an injury that a lot of times has to be treated either acutely if you get on the field, or in an emergency room setting where you have to do some type of anesthesia or some kind of way to reduce that. But like I said, it's more of a spectrum. Both are associated with trauma to the soft tissues. Obviously, a dislocation is much more pathological injury. They can cause a lot more damage both to the soft tissue as well as the bony structures. But again, it's more of a continuum between the injury to the joint itself.
Thank you. So Charles, quick question here. Somebody comes in, they're first time dislocated, or the surgeon decides to treat that instability conservatively, and we'll talk about that in a second. Give us an idea of what your prehab or your rehab protocol, prehab if they're going to have surgery, rehab if you're treating it conservatively, and they're not going to have surgery. What's your protocol in terms of a first-time dislocator, shoulders reduced, maybe subluxes, or frankly dislocates and is reduced? They come in, they've had an MRI, they've been worked up. Surgeon says, look, we're going to treat this non-operatively. Give us an idea of your rehab protocol.
Yeah, so the first thing is to still protect the area as it's healing. So we really work backwards of wanting to avoid mechanisms that could be associated with that dislocation or subluxation. So we're really going to avoid these areas of high torque where you that abducted and externally rotated position. So we're going to work closer to the body. Someone that may be as general as isometrics if it's severe, and then progress from still close proximal loading, and then working on really getting back the retraction and external rotation so that they can keep that shoulder in an optimal position. so that it isn't, either sliding anterior or posterior.
Perfect. Dr. McGarry, so somebody comes in, they've had a shoulder instability episode. What are your indications for surgery? Do you do surgery on first-time dislocators? And how do you make that decision whether they're surgical or non-surgical?
That's a great question. And in my career, that's sort of an answer. You see a lot of these things in orthopedics kind of goes the pendulum swing. I remember when I first was doing my orthopedic training in the late 80s and 90s, if you talked about doing surgery on a first-time dislocator, they'd probably kick you out of your residency. And basically everybody we did back then, we took care of it conservatively. Then to the benefit of a lot of us smart people out there, some studies got to be doing as far as what was the best thing to do for these people. Studies have basically shown that obviously the way to base that decision on is, number one, obviously you need to take care of the acute injury. But the second thing you want to do is make sure there's no long-term problems. Now, obviously the biggest thing that we're concerned about, especially in the young athlete, is obviously it's traumatic. Somebody's arm pops out on the football field. That's traumatic. But what we don't want to see is these kids that have a dislocation that keeps on coming out and recurrently comes out, because that's a catastrophic thing. Studies have shown that the increased propensity is that, or the studies have shown that the chance of recurrent instability is inversely proportional to the age when it first comes out. So that means the younger you are, and as we're talking about now, high school kids, the younger you are when it first comes out, the increased risk that it's going to come out again. And studies have shown that kids are less than 20, if they have a one-time dislocation, the chance it could come out again is up to 90%. So obviously that's impinging upon us as orthopedic surgeons now to say, okay, listen, if you got a 90% chance that it's going to come out again, well, what can we do to treat it? So to answer your question, Dr. Lehman, yes, we routinely now will at least consider surgery early for these kids, because again, studies have shown that surgery early can help out a lot. Dr. Arciero is a guy that did a lot of research in this field. Basically, he had the benefit of working at the United States Military Academy. He got to use a lot of cadets. Well, he basically pioneered a lot of the early work as far as doing surgery for early dislocations. And basically what he found out was that he did a study that said the chance of recurrent instability treated conservatively, those kids that got treated with surgery, was the surgical kids, the chance of dislocation again was much less than 5%. The ones that got treated conservatively, it was up to 80%. So when you see numbers like that, that really behooves you to say, listen, can we do something early to take care of these kids? Now, one of the beauties that we've got to avail ourselves of now is that the role of arthroscopic surgery has come a long way. So we can do a lot better operation than we could do before. So there are definitely some good operations now that we can do early to take care of these kids and hopefully take care of the potential long-term problems. But again, there's a lot of factors that come involved. This is one particular sports injury that really is something you really need to sit down, obviously talk to the kids, but you really need to get the parents involved, coaches involved, really, because this is a decision that's really going to impact a lot of different things. And it's not just a cut and dried answer. It's not like one answer is right for everybody. So it really entails everybody to sit down together, talk about what the pros and cons are, what the risks and benefits are. And those things change. They change depend on, the age of the athlete, depending on what sport they're playing, and it's even things like what point in their season they are. So a lot of different factors come into making a decision. There's not just one right answer. But in the short answer to your question, yes, indeed, there is some good surgical intervention, and it is something I definitely address a lot with my patients now.
Thank you. So is there anything, you see the patient, they've had an instability episode, you come in, maybe the primary care, someone else is ordering MRI. Is there anything on the MRI that would push you one way or the other to say, hey, we're going to send them over to Charles for rehab or Brett to rehab, or we're going to go ahead and fix a shoulder as a first-time dislocator?
Yeah, there's no question. Basically, sort of my sort of absolute indications that I'd consider doing surgical intervention are like, irreducible dislocation, something that can't be reduced, then obviously that's something we're going to talk about doing surgery. If somebody has a significant bony injury, if there is a significant bony bank heart, where there's a chunk of bone off the glenoid, or if there's a significant Hill-Sachs lesion, then that's something that would definitely push me more to talk to these kids and these families about pushing towards surgery a little bit quicker than later. Obviously, other kind of, concomitant injuries, like you got an MRI and they had a big rotator cuff tear, that's something that pushed me more towards having early surgery. And then obviously the other thing is if there's some reason why that from a physical therapy standpoint that the patient couldn't get their arm in a position for functioning, for doing therapy, that's another sort of relative indication out more towards surgery in the early first-time dislocator.
Thank you. So Charles, the athlete has surgery, they come in, basically when do you want to see them post-op? And maybe that's a question to ask Dr. McGarry initially, when he's going to let them start their therapy. And then when they start their therapy, give us a little idea what the therapy entails. Patients had a stabilization procedure, they lost some range of motion, they come in and see you. Dr. McGarry, when do you normally start your rehab, number one, and number two, what's your go-to surgery with somebody who's got an instability pattern, or don't you have a go-to surgery?
Well, I sort of do. Again, it depends a lot on the pathology. But like I said, I remember when I was a resident, we used to do a lot of open, like Bristol procedures, and that was a tough operation. It really was. It was tough operations because it's very hard to see. And I think they used to tell us that one of the benefits of doing that operation was like the hot poker principle. You just mucked around so much in the shoulder, you made so much scar tissue that the kids scarred down, so it took care of the instability. But the advent of arthroscopic surgery has really revolutionized that. So I think sort of my go-to operation on a first-time dislocator, as long as they don't have a huge Hill-Sachs lesion, would be an arthroscopic bank heart repair. And again, the techniques we have now, and the biggest thing, not only the techniques, but also the instruments, the anchors and the different kind of suture material we have now has just come light years over what we used to be able to do. So we can just do the operation so much better. Now, as far as therapy goes, I think this is one operation that physical therapy is almost 100% that we've got to do it afterwards. And again, it's sort of gone in pendulums too. We used to do the surgery, we'd keep people bound down for 6 weeks. And again, I guess that was the whole same principle. Our whole goal back then is the surgery was so kind of iffy that we basically just tried to scar everything down to take care of the instability. Right now, I'll send kids back to therapy, within the first week while they still, still have their post-op bandage still on there, because there are definitely some exercises we can do now safely. Charles already touched on the point that obviously you don't want to put an athlete in a position where you're going to potentially cause increased risk or undo what you did in surgery. But there's no question some gentle range of motion exercises, some isometric stuff is important early, and then gradually you can increase up as you go. Obviously, you asked the question, is there a go-to operation? If somebody has a little bit more of a Hill-Sachs lesion, I like to do the operation just because I like the name. But the Replisage has been a neat kind of operation, too, that adds a little bit to that. Obviously, other down the road, it gets on your top, talk about a little later, a little bit more involved operations like a Latarjet. But that's not something that, in my armamentarium, that's not something I go to a lot as a first-line treatment, unless they've got just a significant bony injury going on with their soft tissue injury.
Thank you. So just to clarify real quick, the Replisage, which is a great name, is a procedure where the orthopedic surgeon puts in some anchors into the Hill-Sachs and brings a posterior capsule to the back of the shoulder to stop something called on-track lesions. You don't want the Hill-Sachs, which is a big gully in the back of the humeral head, to catch and kick the shoulder out. And whoever invented the name deserves probably the Nobel Prize or something. It's a great name. So Charles, real quick, somebody comes in, well, you don't need to be real quick. Somebody comes in, they've had a surgery, Dr. McGarry sends them over, they had an anterior stabilization, they had a arthroscopic bank heart, no big bony lesion. They show up at the clinic. How are you going to treat that athlete?
Yeah, so there's a little variance, again, based on severity of the procedure. I've seen them as early as 2 days post-op in 2 weeks. That's usually a timeline, that if they want them to kind of scar down and have that stability, you don't mind if they get a little stiff within the first 2 weeks. So that's usually when I've seen that 7 to 14 day at timeline. So your rate of healing, it usually fits along there. But there's, again, can be a little variance. We want to protect the site, address if there's any wound care issues, and make sure that there's no, obviously, infection. So we check that as a primary. And then we just begin with some, what I would say some manual therapy, some passive range of motion, and even some active assisted, where they're starting to move in a lightly flexed position and lightly externally rotated position. Again, I've had shoulders that feel tight right away and others that are smooth. Now, you want a little bit of restriction because you don't want them to have that, elevated risk anymore. So it's a gradual improve, 20%, maybe by week to week on how you're going to improve in each little position. And then really working on, again, the scapular stabilizers, working to the motor recruitment and the motor pattern to have that control of the rotator cuff and everything that helps with elevating the shoulder. So we focus on that pretty early before they have any type of return to sports, and really the first 6 weeks.
And Charles, athlete has their surgery. When can they go back to collision sports or any type of sports, swimming, non-contact sports, and then give me contact sports and collision sports?
Yeah, I've seen athletes as early as 16 weeks, but that's that full-on contact going in. Again, usually you're looking at a timeline of 4 to 6 months, but that could vary based on what time frame they've had a procedure, if it's a potential senior season. So those are sometimes the timelines we try to respect, but also really the rate of healing is the biggest thing. Most people, if you're a throwing or an overhead athlete, it's going to be a little longer. It may be up to that eight plus month if it's kind of more larger repair. So then you've got your return to throwing phase, which is different as well if you're a non-contact athlete. Well, I say a non-throwing athlete.